So I really want to turn this over this morning and get us started to Richie Johnson. She's going to be leading a panel discussion today on disparities and access to care in kidney cancer. And so I'm going to turn this over, and Richie, if you want to go ahead and introduce your group and kick us off on this Saturday morning. Hopefully all caffeinated and ready to go.
Well, good morning. I am extremely excited to be a part of this virtual Kidney Cancer Association Symposium this morning. Our session this morning will focus on disparities and access to health care. We have Dr. Pedro Barata that will be starting off this morning. He is the Assistant Professor of Medicine at Tulane University Medical School. Dr. Barata will speak on building a kidney cancer program in Louisiana. And the other two speakers will be Dr. Pavlos Masal. He's Assistant Professor of Genitourinary Medical Oncology at MD Anderson Cancer Center here in Houston. And then I will speak a little bit on health disparities and access. I am a member of the KCA Patient and Caregiver Advisory Council, as well as president and founder of the Chris C.J. Johnson Foundation. We also have Dr. Melanie Ross, and she will speak on clinical access. She worked with the Office of Oncology Diseases and the Center for Drug Evaluation and Research at the U.S. Food and Drug Administration. Without any further delay, I would like to have Dr. Pedro Barata to come on and speak this morning.
That's great. Thank you. Thank you so much, Richie. It's truly a pleasure. Thank you for the invitation. It's a pleasure for me to be here, be part of this panel and this session this morning. I'm really excited, for the session. And thank you for your kind introduction. So I have GU background. That means I only treat kidney, bladder, and prostate cancers, right? And when I moved to Tulane, New Orleans, in Louisiana, and I did it in 2018, so 3 years ago, I found quite a different reality from what I was expecting and compared with my life at Cleveland, where I came from. So that's kind of what I decided to talk a little bit today. I think I have 10 minutes. I'm going to try and stay on time. And these are my disclosures, by the way. So I'll show you a little bit of data, facts about the state, and then I'll show you what we've been trying to do, to raise awareness for kidney cancer in the region. I was actually quite shocked, when I saw these numbers. And I'll tell you, we just had tumor board yesterday, and I keep hearing my friends from urology, the surgeons, right, who keep saying there might be something in the water because, we treat more kidney cancer here than anywhere else. And interesting enough, I've seen these numbers quite a few times now, but I think it's really, but I'm sure not all of us actually know of these data. So when you look at the incidence rates, of renal cell, kidney and renal pelvis cancer, which is not exactly the same, but for the most part does capture all kidney cancer we'll be talking about today, you'll see the incidence is extremely high, and it's high in white patients, also in Black patients, and it's actually higher than the average for the United States. And on the right side, you'll see that it's, the state, that little book there, it's in red. And guess what? It ranks first in terms of having the highest incidence of kidney cancer among all states within the United States, right? And so this was really a problem, and this kind of confirms what I keep hearing, almost every week from my friends from urology saying they've never seen so many patients with kidney cancer. And when we dig in a little bit further, and we kind of see, if that's something about a specific location or county, within the state. The reality of it is, it seems to be, all over, right? You'll see there, New Orleans, Baton Rouge, but you keep going, and you'll see the incidence is high, no matter how you look at it. And the other part of the story, although these numbers stop in 2014, that's the numbers we have, by the way, from Louisiana Tumor Registry, and the numbers have been rising over time. I think there's a number of factors for this. I mean, obviously, the fact that perhaps people might have more access to care, and so they are found with more localized masses in the kidney might be one explanation, but it's definitely important to look at these numbers. Now, and that's part of the suspicion. I think part of that might be, perhaps we're giving people more access, is the fact that a good portion of these patients are found with localized, kidney cancer, which is not a bad thing in the context of, you want to see more people with more localized disease than people with distant disease, stage 4 disease, if that makes sense, right? We still have a good percentage of patients who are unstaged, who are categorized as unstaged in these registry, which, we don't know. It's more than a third. So I'm not entirely sure if, if they are only localized or perhaps more, local, regional, and distant disease. But that's the distribution we know about this region. So I talked to you about instance, and here's a slide about mortality. And again, this is, to me, this is very important, not for the good reason, but it is very important for us to know that, again, patients with kidney cancer diagnosed here in Louisiana are among the highest mortality rates across the nation, right? And so we compare not favorably, with other states in the country. And again, we are in the red. So we are at the state, and I do practice in a state that has the highest incidence, the highest mortality. So this is definitely an unmet need. And I kind of felt that, when I got to Tulane, to be honest and fair, we didn't have a program. We didn't have a kidney cancer program. And so we try to change that, right? And so one of the things we did is trying to understand who are the players in the region, kind of partner with them, who are the players in the nation. We kind of knew, including KCA, et cetera. And we put together kind of a plan. We got a plan in motion to change this, right? So I'm going to go through, the next 3 or 4 minutes, the few things that we've done with our colleagues and friends in the community to change this reality, right? And so one of the things we're really invested, so we got 3 points. One is clinical part, offering services to patients and raise awareness so that patients can see us. The other perspective is the research perspective, and finally the education perspective, right? So on the educational side, there's a bunch of activities we've done in these last 3 years here in Louisiana. It includes the first inaugural, Kidney Cancer Day we had in 2019. This was supposed to be an annual event. We didn't do it last year due to COVID, but it was a success. We had a number of patients here. We had patient advocacy group here too, and very nice speakers, and so I really felt we were starting building a community. We also had help from, which, by the way, thank you to Friends Foundation and KCA to help us put together programs with the community. So we've been doing a lot of that. So we go out there to the community, talk to the community doctors, how to treat kidney cancer. The ECHO program, which is a great, wonderful experience I had, happened early this year with our friends from North Shore and Our Lady of the Lake, and where we met regularly to go over, a number of talks with kidney cancer, a number of cases, clinical scenarios, so difficult patients. So that's great experience. We have a number of roundtables and workshops. I try to take all the invitations to do that in the region, so that I have the opportunity to meet with basically any team that treats kidney cancer in the region. And finally, we've been trying to be, strong in different platforms, including very well-known platforms that physicians and care providers and teams use to get knowledge about kidney cancer. So we've done a number of those too. In regards, when we talk about research, I'm going to stop here for a second, talk to you a little about research, because I truly think that's where we change things quite a lot. First, we have no trials. When I got here to New Orleans at Tulane, I have to talk highly of LSU, which I'm going to do in a slide. But right now, for instance, we have 9 kidney cancer interventional studies. And when I look at LSU through NCORP, which I'll talk to you in a second, we now have almost 20% enrollment for Black patients with renal cell carcinoma. And these numbers are for this year. They can always be better, but the numbers are definitely way better than they were 3 years ago, which is quite remarkable. Again, this is not Tulane alone. This is actually an effort from NCORP, which I'll show in a second, is an effort throughout the state, in addition to us, right? And we're very strong bringing the NCI partner and, the cooperative groups, SWOG, NRG, Alliance, who basically put very thoughtful trials in oncology and trials in kidney cancer, and we use them to actually offer treatments to patients, right? And then the translational research and philanthropic support are actually been increasing as well. So allow me to give credits where it's due. So In reality, LSU was really doing a fantastic job as part of the NCORP. So NCORP is the NCI Community Oncology Research Program. There's a number, I think there are 14 programs like this in the country for minorities, for underserved populations. And this one, the Gulf South the minority group is one of those groups. And Dr. Ochoa is the PI, but I kudos to Dr. Gills and Dr. Westerman because they're being my counterparts at LSU and, and have been helping with those accruals as well. So we're offering clinical trials to an underserved population and then definitely help, to get to the 20%, 80% right now of the enrollments are actually African-American. And in reality, due to the effort that my friends and colleagues as well have done here. And look at the map, right? It's not very nice to see that a lot of groups out there are being part of these, these efforts. So that's a very important initiative and program we have going on here in Louisiana. Finally, we put our own program together. We got a bunch of things going on. We're very proud to have now patients involved, in the kidney cancer community. We have, patients who share their stories. They're both Tulane patients in this case, will share their stories at the KCA portal. We had, as I said, a very nice support and very important support from Kidney Cancer Association, Friends Foundation, and actually opportunities like this one are perfect for us because we can continue to put Louisiana on the map. So, I want to thank, patients and families for the support, colleagues that I have in the region, obviously our partners. I do think there's a lot for us to do more. I'm happy where we are. I don't think we've done enough, but I do see it. I think the future is bright, and I am hopeful that things will continue to improve and we're able to offer the best treatment in the world, world-class care to Black patients and underserved communities, who are diagnosed and will be diagnosed with kidney cancer in this state. And so I'm going to stop here, and I'm happy to take any questions. Again, thank you so much for having me on this panel today.
Thank you, Dr. Barada, for such a great information. And I do expect to hear from you and with more success stories. Is Dr. Pavlos Masal available?
Yes.
Good morning, Dr. Masal. We're happy to have you this morning. And we will go on and let you get started.
So thank you all for attending this presentation titled Renal Medullary Carcinoma, Black Lives and the Fierce Urgency of Now. Let's see. Are the slides moving?
Yeah, go ahead and hit slide number 2 with your mouse. There you go.
Okay, there it is. These are my disclosures, and none are pertinent to this presentation. And one thing to keep in mind and that I always highlight to our patients is that kidney cancer is not a single entity. So very often on the internet, we hear or read about kidney cancer overall as it is a single entity, but it is not. It is multiple different cancers, each one of which is treated differently. So it is very important that when you're diagnosed with kidney cancer, you know the histology, the type of kidney cancer that you're diagnosed with. And the one that we're going to focus on today is renal medullary carcinoma, abbreviated as RMC, which is found in less than 1% of kidney cancer cases. It is a rare cancer, although now we realize it is more common, probably 10 times more common than we used to think 5 to 10 years ago, but still a rare cancer. But it has some very critical characteristics because, as you will see, it afflicts young, vulnerable individuals. And in this paper, we highlight a lot of distinct features for this cancer and other cancers as well. So a few clinical facts about RMC. It was first described in 1995, so a relatively recently diagnosed entity, although it has been with us for many, many decades, possibly centuries. And it predominantly afflicts African Americans with sickle hemoglobinopathies. This sickle hemoglobinopathy is a term that encompasses the blood disorders that include sickle cell trait. So even if you have sickle cell trait, which for many patients doesn't cause any symptoms and most of them live long and healthy lives, you may still be at risk for developing RMC. Or if you have sickle cell disease, which people who do have sickle cell disease will know that they have sickle cell disease because it causes pain often and many other symptoms, or other hemoglobinopathies that cause sickling, not the ones that do not cause sickling. So thalassemias alone are not related to RMC. And in less than 5% of RMC cases, that's very, very rare, the patients will not have any sickle hemoglobinopathies. We use this medical term here in those cases, RCC-UMP. It's essentially a subtype of RMC. It behaves very much like RMC, although we're learning now some distinct characteristics of that entity. And critically, RMC occurs in young individuals. Average age in the mid-20s. People can be as young as 4 years old, that's the youngest that I've seen to date, or as old as 69. And it is more common in men than women. And it is also much more common on the right kidney, 3 times more common on the right kidney than the left one. Let's see, next slide. Oops. Sorry about that. There it is. So the other thing to keep in mind is that it is that even though it's a rare kidney cancer overall, it is the 3rd most common kidney cancer in children and young adults. And 1 in every 20,000 individuals, we believe these days, that have the sickle cell trait will develop RMC. And keep in mind that there are 3 million individuals in the US with sickle cell trait. And we see at MD Anderson in our clinics about 1 to 2 new cases per month of RMC. They come from all over the country. And there is double that number that we hear of and we try to help from afar and we don't see. They're unable to come to Houston. So let's say 3 to 4 new cases of RMC per month with 3 million individuals with sickle cell trait in our country. But there are 300 million individuals with sickle cell trait worldwide. That means that we should expect about 200 to 300 or even 400 new cases of RMC to be happening worldwide. That's more than enough to run big phase 3 randomized clinical trials for this cancer. So not that rare. But what happens is that most of these patients are in Africa. And this is why this is such an under-recognized disease. Let's see, next slide. There it is. So most patients with RMC will have metastatic disease. The cancer will spread to the lymph nodes, the lungs, the liver, the bone. And even those that initially don't have metastatic disease, if we wait too long, and when I say too long, a month or so, they will likely develop metastatic disease. So it's a very, very, very aggressive kidney cancer. And it has some distinct characteristics like the fact that it does tend to go to the heart more frequently than other kidney cancers. So it can cause an entity called cardiac tamponade. And that's something that clinicians that take care of patients with RMC should be aware of. And then the presenting symptoms, usually patients will present with blood in their urine. That's what we call hematuria, or pain in their flanks, more likely in the right flank because more likely this kidney comes from the right flank. And they may also have what we call constitutional symptoms like night sweats, weight loss, etc., or difficulty breathing, cough, or pain. Next slide. So the other thing about this cancer is that the treatments that we normally give for other kidney cancers, like clear cell kidney cancer, are completely ineffective against RMC. So the tyrosine kinase inhibitors, the targeted therapies like sunitinib, pazopanib, cabozantinib, all of these therapies that may work for other kidney cancers are like giving water to patients with RMC. They don't work at all. And unfortunately, we now know, we haven't yet published that widely because we're still interrogating the data, but we're pretty confident that the currently available immunotherapies are also ineffective. And what works for RMC are the chemotherapies, the platinum-based chemotherapies that do not work against most other kidney cancers. That's why it's so important to know that you have RMC as opposed to other kidney cancers. That's why that correct diagnosis is critical. The average survival used to be 3 months from diagnosis. In 2017, we found that it has improved to 13 months. And now we believe, we haven't formally proven it, but it's more than 13 months nowadays. It's 18 months, maybe even up to 2 years, the average survival. Better. Slow, steady improvement. Research helps. Research makes a difference, but still, we haven't reached the goal, not even close. We need to find ways to cure 100% of these patients, because right now, even 90% of these patients will succumb to their disease within 3 years. So we need to develop better treatments, and we need to find how to diagnose this earlier. Next slide. So these are the faces of RMC, and you see young individuals of African descent mainly. These are the patients that we typically see. I'm very grateful to the support organizations linked here that has spread awareness and helped support the research and other efforts that we do for RMC. Next slide. So advocacy is making a difference. So you can see here, Richie Johnson, who is here with us on the panel, she has done an amazing amount of job, including writing a book about her story. She turned her story of losing her son to this cruel disease into passion, into energy, into something that is helping individuals with RMC all over the world. And here is exactly, you can see this advocacy network that she does, regular meetings where patients help each other. That makes a difference in ways that physicians or other researchers cannot do. She also does, every year she organizes the 5K run walk fundraiser in Houston, reading support for research with RMC, peer-to-peer support works, patient advocacy, so crucial. I can guarantee to you the changes that we have seen in RMC in the past few years and the ones we're going to see in the coming years would not have happened without that patient advocacy. RMC is the paradigm of the power of advocacy. Next slide. And there is hope. There is hope. You can see here the story of Herman Connor. He is a survivor. He shares his story. He's been alive. He came with stage 4 RMC at our institution and was told that he was going to die, and now he's alive and disease-free. He doesn't have RMC, as far as we can tell, for more than 7 years, and he's not alone. We have, I'm pretty sure now, more than 8 or more than 10 patients with legitimate stage 4 metastatic RMC that we have been able to remove completely so that they're disease-free. It's not all of them, far from it. It's only 5 to 10% of cases still. But there is hope, and we want to make that 5 to 10% 100%. Next slide. And his sister, Herman's sister, Cora Connor, is also a fierce patient advocate, raising awareness about RMC. Next slide. And because of all these collaborations, we have guidelines. And these are the kinds of guidelines that need to be shared with the communities, not just with patients, but with clinicians as well. Because it's important that clinicians identify RMC early and treat it properly using these guidelines and using the upcoming information in our RMC Alliance website. I'm pleased to tell you, to announce that in the next few weeks, the website will be up and we will be providing updates, ongoing dynamically updates, because things are moving fast with RMC. Next slide. And also of importance, we have YouTube videos now that has also made a big difference. YouTube and social media are a powerful avenue to raise awareness. This video that we made in January 2020 has been seen now by more than 6 million people through YouTube and twice more through Chinese channels. So that has raised, this is an actual case of an individual with RMC, that has raised awareness. Next slide. Another one, that one we just uploaded exactly a month ago, and a few days ago when I last checked, it had more than 1 million views already on YouTube. More than 1 million people now know about the story. And this is actually the story of Herman Connor. And in addition, we uploaded a discussion, a scientific, more detailed discussion for physicians, researchers, etc., which is also being viewed a lot in YouTube. So it makes a difference. And also, Herman Connor shared his story. The second video is actually his story, dramatized so that people can, be involved. And Herman Connor in this last video shares his story, what happened, how was he diagnosed, and a very passionate, powerful story. Next slide. And here is what awareness. This is such a powerful message on one of his videos, because this is the sibling of an individual who died at age 30 and was told that it was kidney cancer, but that brother checked all the same boxes as Herman, and now they realized by watching these videos that this was almost certainly RMC. It fits all the boxes. That's how raising awareness can even comfort people to know, even decades later, what happened to their family members. Next slide. And because of all of this activity, we do have dedicated clinical trials just for RMC. We have the first immunotherapy clinical trial just for RMC. We'll publish that shortly. We finished that one. We have this ongoing clinical trial. And here is the proof that you can do clinical trials for rare cancers, even less than 1%. Why? We opened this trial in August 2018. We did not have funding to open it anywhere else other than MD Anderson. It takes a lot of support to even open it at MD Anderson. And yet, despite the COVID pandemic and all the delays that imposed, within 3 years, we've almost finished accruing the trial, 27 out of 30 patients, a lot of sacrifices, including from our patients, but we're getting there and we're pushing forward. And this is something that industry and the academic communities are noticing. They're noticing, oh yeah, they can do it. So maybe we can keep doing it for RMC and other rare kidney cancers. It's possible. Next slide. But to achieve this, it takes a village. That's the way to move things forward. When you're dealing with such a rare cancer that's so aggressive, and because of various structural reasons has been invisible for so long, it needs to be a work of many, many, many different people from all aspects: research, clinicians, patient advocates, statisticians, methodologists, and organizations like the KCA. The KCA was the first organization, along with the Concord Cancer Foundation, to ever provide support for research for RMC through the ASCO YAA. Then the KCA supported us through further YAA, and we have other organizations as well after that keep pushing all of this, the Department of Defense, KCure, all of this, and through all of that, the connecting thread are our patient advocates, Richie Johnson, Cora Connor, and others now joining in this effort. Next slide. So thank you very much for your very kind attention. Happy to answer any questions. This is my contact information as well. And again, I'm very, very happy to announce that the RMC Alliance website will be going up soon.
Thank you, Dr. Masal, for such a beautiful presentation. And I can honestly tell you that progress has been made. Back in 2011, when my son was diagnosed, we didn't have any treatment modality specific for RMC. So I really appreciate your energy and your compassion to the RMC community. All right, now it is my time to present to you regarding health disparities. Health disparities are differences and are gaps in the quality of health and healthcare across racial, ethnic, and socioeconomic groups. The disparate impact of the COVID-19 pandemic, ongoing incidents of police brutality, and recent rise in Asian hate crimes have brought health and healthcare disparities into sharper focus among the media and the public. However, health and healthcare disparities is not new. They have been documented for decades and reflect long-standing structural and systemic inequities rooted in racism and discrimination.
Can you hit start presenting at the top there?
Oh, I thought I did. Okay. All right. Now, access to health care is continuing to be a problem. Of the 30 million uninsured Americans about half are people of color. Even though more African Americans are insured, challenges continue to exist and have an impact on African American and people of color. Racial and ethnic minorities may face multiple barriers to accessing medical care in the United States. Issues such as lack of insurance, transportation, childcare, or ability to take time off from work can make it hard to go to the doctor. Cultural differences between patients and providers, as well as language barriers, affect patient-provider interaction and healthcare quality. When they receive care, it may not be equivalent to that for other groups. Why is this so? However, it's a complex issue involving not only possible differences in ability to pay and provider behavior, but also in such factors as patient preferences, differential treatment by providers, and geographical variability. In the United States, there are significant racial disparities in access to health coverage and health outcomes. People of color are far more likely to be uninsured in America, due in part of several states' refusal to expand Medicaid. 14 states have refused to expand Medicaid under the Affordable Care Act, which is one reason why people of color are disproportionately likely to be uninsured today. So why is there a concern? 1 in 3 residents of the United States self-identify as African American, American Indian, Alaska Native, Asian, Native Hawaiian, Pacific Islander, Hispanic, Latino, multiracial. It is predicted by 2050, this number is expected to increase 1 in 2. Despite significant advances in civil rights, race remains a significant factor in determining whether an individual receives care, whether an individual receives high quality care, and in determining health outcomes. Key facts. Raise public awareness is extremely important. Perceptions of a problem often influence the actions taken or not taken to change policy and practices. If the public or providers are unaware that a problem exists or misunderstands the nature of the problem, it can be difficult to direct resources to address that problem. Effort to raise the public awareness of racial, ethnic health care disparities have achieved modest success. Surveys have shown that physicians and medical staff disagrees the minority patient generally receive low quality care as compared to the white patient. Health insurance matters in determining whether and when people get necessary medical care, when they receive care, and how healthy people are. Expansions to health insurance coverage are particularly important to racial ethnic minority groups. Efforts are needed to assure that existing sources of coverage such as Medicaid are maintained, while also working to expand other sources of coverage for those who are uninsured. Improving the number of providers in the underserved communities. Despite the efforts since 1970s to increase the number of health professionals in medically underserved areas, members of racial, ethnic minority groups are still underrepresented in the healthcare workforce and are more likely than whites to live in the neighborhoods that lack adequate health resources. Approaches to strengthening communication and relationships between patients and providers include greater use of medical interpretation services. Expanding the racial, ethnic diversity throughout the community is extremely important. Increasing, how are we going to address these healthcare disparities? And as I had mentioned, awareness is the key. And then basically there's use of telehealth as a way to improve access, but then you have to look at it in another way. Some may not have access to the computer and education as far as how to even use the computer. Remove challenges in navigating the healthcare system is extremely important. Sometimes it's just too difficult to navigate through the healthcare system. In summary, eliminating health disparities will likely require a cohesion of multiple strategies, but successful efforts have the potential to increase expectancy, quality of life, and reduce healthcare spending. As a nation, we have an abundance of healthcare facilities, cutting-edge technology, and other assets that are the envy of the world, but serves no purpose if individuals are denied access for various reasons. Disparities in healthcare for people of color and underserved groups are a long-standing challenge, as I had mentioned before. Yes, the COVID-19 pandemic has exacerbated these disparities and heightened the importance of addressing them. Health disparities are driven by underlying social and economic inequities that are rooted in racism. Addressing disparities is important, not only from a social justice standpoint, but from improving our nation's overall health and economic prosperity. It is extremely important. We had an opportunity to just witness in the REMC community. We had a patient that lived out of state, was sent home by her physician in her state saying there was nothing else that they could do for her. And whereas in reality, if she had had access to MD Anderson, she possibly would have had an opportunity to have more treatment modalities. So health disparities is real, and creating awareness and changing the policy because people's lives do matter. I thank you. And then our next presentation will be Dr. Melanie Ross.
Oh, you're muted over there. Oh, you got it.
Yeah. Good morning, everyone, and thank you for participating in this virtual patient symposium. And I would like to thank the KCA for this invitation to speak with you this morning. I apologize in advance because today is Saturday and my neighbor is mowing his lawn. So if you hear the mower on the background, my great apologies. I'm Melanie Royce. I'm a medical oncologist and joined the FDA approximately 2 years ago. But before that, I was a practicing physician with a practice in a state that is primarily minority and underserved. That was New Mexico. Some people even told me, why did you move out of the US and went to Mexico? Hello, it's New Mexico. New Mexico is part of the US. All right, so that's some of the misconceptions of folks. But anyway, going on to my presentation now, okay, there it is. I have no financial relationships to disclose. Since I work at the FDA, I am going to talk to you about initiatives of the FDA, in particular the Office of Oncologic Excellence, in terms of addressing disparities and access to cancer care. The first one that I will talk to you about is Project Equity. Project Equity is a public health initiative by the FDA Oncology Center of Excellence to ensure that the data for approval of oncology medicinal products adequately reflects the patients for whom the medicinal products are intended. The aims are to ensure that FDA-approved medicinal products works for all. And when we say all, not just a majority population representation, but really that it represents everyone in this melting pot country called United States of America. Project Equity, let me go back, sorry. Project Equity works to improve access to clinical trials of oncology medicinal products for populations that are historically underrepresented in clinical research, such as racial and ethnic minorities, individuals who live in rural areas, sexual and gender minorities, and individuals with economic, linguistic, or cultural barriers to health services. Now, Project Equity works in two ways. First is access. Clinical trials provides patients the opportunity to access potentially promising investigational treatments. And when we say investigational treatments, these are drugs that are not yet approved for general use for that specific disease. However, they may be especially important when standard treatment options provide limited benefit or no standard treatments exist. For patients with serious and life-threatening diseases like cancer, quick access is important. They have no time to wait. Secondly, it generates data. And what does that mean? Clinical trials are the mechanism by which sponsors, this includes pharmaceutical companies and organizations, collect the data needed to evaluate the safety, effectiveness, and dosage of cancer treatments. It is important that clinical trial participants reflect the population that will use the treatment once it is approved by the FDA. Often, the data collected from diverse populations improves the FDA's ability to understand the disease and how it responds to treatments for larger proportion of patients who eventually go on to receive the drug once it is approved. Next slide, please. Okay. So Project Equity goals are therefore to develop and promote policies to ensure adequate enrollment of historically underrepresented and vulnerable subgroups in oncology clinical trials intended to support FDA approval to evaluate any differences that may exist in these populations. We engage and collaborate with internal as well as external stakeholders on research, policy, and educational initiatives to promote access to and advance equity in clinical trials. We also conduct and present analyses of data generated through clinical trials and other data sources to evaluate outcomes across subgroups. So for instance, if there is a class of drugs where that's been already approved and we have the data, but each clinical trial only has a limited number of a racial minority, we can pool that data because the FDA has all that data submitted from all sponsors and generate that data and present it to see if we can have a better picture of how the drug works in a particular subpopulation such as Hispanic, African American, etc. Next slide, please. Okay. Another initiative that we have is called Project Community. And Project Community is main objective is increasing minority participation in clinical trials, pretty much like what we have with Project Equity. But more importantly, increasing knowledge and minority participation in genetic database. We have very few information for minority population in terms of genetic databases. We have decent information for the Caucasian population, but for minorities, we do not. So how this project community does this? First through education, number one. We have what we call Conversations on Cancer, which we talk about various topics. This coming October, we will be having a topic on Latinx and LGBTQ population. What are the disparities they face? How can we improve access to clinical trials? There have been many other conversations on cancer that have occurred, such as with Native American population and with African American families. Actually, we was our last conversation, not just patients, but African American families. We also speak about precision medicine. We, in fact, created a video that's accessible on YouTube as an example for efforts to increase awareness on participation in genetic databases. Lastly, we also have what we call Project Facilitate. Project Facilitate is a single point contact where FDA oncology staff will help physicians and their healthcare team go through the process to submit an expanded access request for an individual patient with cancer. FDA's expanded access program provides a way for patients with serious and life-threatening diseases or conditions, such as cancer, so that they can try investigational medicinal products for treatment when satisfactory therapies are not available and there is no opportunity for the patient to participate in a clinical trial. So for instance, if the clinical trial is only at MD Anderson and the patient lives in a very rural area of Louisiana, Mississippi, whatever, and they do not have access to that one clinical trial, they can request the FDA to see if they can access the drug, meaning to say, when I say they, the physician and the healthcare team can request the FDA to help access the drug so that the patient may avail of that drug, even if that clinical trial is not available for them. I would like to reiterate, however, that whenever possible, an investigational medicinal product should be used as a part of a clinical trial. But this is another way they can access it if they do not have access to the trial. Thank you very much for your attention. That just highlights some of the initiatives of your FDA in terms of addressing disparities and access. I have put here in the last slide some relevant contact information for the 3 initiatives I have highlighted this morning if you want to contact the FDA or want additional information. Thank you.
Thank you, Dr. Ross. I do have a question. What are you doing to really make the public community aware of all the different great projects that you have going on?
So first of all, the FDA has one website. 2, we also have a YouTube channel, which a number of our activities are already posted there. But more importantly, we have public announcements that tell you about any upcoming conversations on cancer, for instance, upcoming guidances for people to read, and also before we finalize any guidances or any sort of regulations that we have a public forum where the public can put their input, their comments, and those are all taken into consideration, read, so that the input of the public is actually well documented before we finalize any guidances or regulations.
Thank you very much. We do have a question from the audience. I believe this is directed to Dr. Masal. How do healthcare disparities affect patient outcomes in patients with REMC? And do you see prognosis affected because patients don't have access to care or present at later stages?
Oh, what a beautiful question. Well, I would reply with, how do they not affect outcomes, those disparities? Because they clearly affect outcomes. For example, to give you an example, because of lack of access to care for these patients, and why the access to care? Because they're young, and people in their 20s often don't have insurance, and or when they're 18 or 19, etc. And they are a vulnerable minority, so they may not have insurance, they may not have access to care, they may have blood in their urine, and they don't know who to go to. And when they do, very often, again, there is disparity in the evaluation. You will see on the YouTube video, now we can tell that story, that Herman Connor was told that he has HIV nephropathy, even though he doesn't have HIV, and there was a mass in his kidney. That's a disparity. That's that whole bias that somehow he had HIV nephropathy is a disparity. It's real. And with RMC being so aggressive and so deadly, we cannot afford to lose even weeks, not the months, the 3, sometimes, or 6 months when it comes to that. And as one of the ways that outcomes are being improved, thankfully for RMC, but not fast enough, is because we're raising awareness and trying as much as we can to the best of our ability to make people know in the communities that, hey, the RMC is real and we need to diagnose and treat it early in the proper way.
Thank you, Dr. Masal. Now, Sally, do you have questions?
Yeah, friendly medical director popping back up again this morning. This one would actually go to Dr. Barada. When you think about the rural patient population, or population that at least isn't more like the MD Anderson Center or somewhere at Dallas, what do you think are some of the biggest struggles with those patients in, once they get a care recommendation, being able to follow through with the care, or struggles particular to those rural patients?
That's a loaded question. I think there are a lot of regional differences, to be honest. So for instance, in Louisiana, there's a lot I've learned about the population here that I was not aware of, right? So typically, patients here don't like to cross bodies of water, don't like to, drive 3-4 hours, for instance. It's a urology-driven state, for example. So all of those things are very different among states, and so there are definitely regional differences that could explain, in part, why people are more open to explore second opinions, go to academic centers. So, for instance, I used to say this a lot in Cleveland, right? 1 out of 3 patients that I was seeing, I was discussing clinical trial portfolio with them. They would come to me specifically about, what trials do you have available for my disease? I don't remember the last time that happened to me in New Orleans. And so there's a different patient population, and those differences are relevant, right? And the other thing is, there are definitely social, cultural change differences. So chronically, I think when I think a clinical trial is the best option for a patient, a lot of times patients do follow that recommendation, if you will. And so my the number of times patients come to me and say, I'm not really interested in doing a trial, I'll do something else, in general is really low. Saying that, for this talk, I was going over the number of patients in the recent past that actually have refused to be on a trial. And believe it or not, the majority of the small number, so the small number effect certainly, but the majority of them were African-American, right? I can come up with 5 patients, 4 of them were African-American, who were really just not interested, right? And so there's definitely, differences there, social, economic, in regional differences, that I think one should be aware of, right? Most of my patients, half of my population actually drives 2 or more hours. So, and that's, and just to get to New Orleans, they just hate coming to New Orleans, to be fair and transparent. So I'm sure in Houston, in Texas, might be a totally different scenario. It might be different in Alabama, it might be different in Mississippi, etc. Right? But these are just some of the factors that I think we might control more or less. I honestly feel that some of these factors I actually don't have a lot of control yet. And that's what I meant by, we need to do put additional effort and energy in improving that. For instance, I'm thinking maybe we should get focusing on the patient advocacy group or someone to bridge the African American community with us, through church, for example, where I had a few patients, African American patients came to me with someone from church, just to explain to them, in a different way, whether or not the trial would be a good idea, for example. So I think that's a lot to do. I don't know if I answered your question 100%, but I'll leave it at there for now.
I think that, thinking back to yesterday when we talked about shared decision making, sometimes it's not just about the medicine itself or the treatment that needs to be discussed, but the things in life that are getting them, going to be a struggle to make the appointments if they're living a couple hours away, and making sure they're able to make those appointments. One of the other big things that has popped up, and this is something maybe Dr. Royce could speak to a little bit, language can also be a barrier. Although, a lot of centers may or may not actually have somebody who's Spanish speaking. That's not the only other language that sometimes people need to speak. And so what can patients do if they're struggling with the language barrier in terms of understanding their health care or their condition?
So that's an actually very great question. Just to let you know, for instance, when I was practicing in New Mexico, in Albuquerque, we have a large Native American population. Now, Navajo interpreters don't come easy. So can you imagine if you had a Native American patient and you had to explain to this culture who doesn't even have a word for cancer? So you need somebody there that is culturally attuned to this culture to explain to them the diagnosis of the patient. Fortunately, at the University of New Mexico, we had Navajo interpreters because of the, over 10% population of New Mexico is Native American. But if you don't have access to that, remember that the American Cancer Society, it's not ideal, but you can call that number for language interpretation. It can be provided, and it could be in evenings. They're available in evenings. Now, sometimes the interpreter is not readily available. You'll have to wait a few minutes, but there is a way, there is a get around, so to speak, for some of these barriers. You just have to think about what are some of the creative ways to do it. Now, when you're sort of stuck, most physicians use family members. That is, I guess, okay, but less than ideal, because, some family members may want to protect the patient, so to speak, and not tell them exactly what you're telling them. And I know this for a fact because although I don't speak Spanish, I can understand it fairly well. And when I have a Hispanic patient, I'm trying to explain something to them, I see sometimes that the family intervenes and explains it in sort of not full disclosure, so to speak. So it's important that we have interpreters available. That's, I think, something that all centers should have, at least of the most common languages used. So Hispanic definitely would be one of them, and whatever else is most common in your state or your catchment area.
I know when I worked at one of the hospitals in Houston, they actually did have a hospital interpretive service that could be provided, whether it's a patient who's deaf or different languages. I think the first thing is making sure if you can get a health trained, some medical trained interpreter, because some of those terms are really hard for people who don't know the medical terms in English, let alone in other languages. The same, thing exists. But like you mentioned, the family members sometimes shorten or abbreviate or lessen sort of what is being translated. But you do what you need to do as well to get that information. And one last question that would go to Pablos. When we think about conditions, like RMC, where the numbers are rare, how is it that, whether it's patients who have these conditions, maybe if their doctor's not as familiar with them or the research that's available for them, how do we find a way to get these studies? You had one that was up there with 30 patients. Other studies for clear cell renal carcinoma, you see maybe a couple hundred patients. How do we try and get that recruitment for those rarer cancer patients to involve themselves to improve those trials?
A great question, and the answer is awareness. The way we've achieved this for RMC is through patient awareness. And how did we achieve that patient awareness? By the initiatives in social media, and Richard Johnson is a main player in that. Somebody who is diagnosed with renal medullary carcinoma and Googles renal medullary carcinoma and finds Richard Johnson or Cora Connor or our other now many patient advocates that are joining in this fight. And then they get connected in the RMC network, let's say, of people that help each other. And then the advocates do their absolute best to help out because there are a lot of challenges. You know, some patients cannot come to Houston in these trials. And what happens in this case is that they often connect their doctors with us, and we do our best to help. I personally, I've lost track of the number of patients that I've never met in person and that I help through, you know, they're talking to their local physicians, sometimes even in multidisciplinary meetings, Zoom meetings with the physicians, etc. And that's how, through that patient advocacy network, that we've been able to do that for RMC. And I think that if we can do that for RMC, we can do that for other cancers. We can do that for translocation. We can do that for chromophobe. We can do that for many, many other rare cancers.
Sally, let me just also state that clinicaltrials.gov lists a number of clinical trials that are ongoing for any provider or patient that wants to look up if there's any clinical trial available to them and where it might be.
Absolutely. And we do have a whole sort of Facebook series that's been recorded at the KCA on clinical trials and some suggestions on how to navigate finding them. We have our patient navigator program, and we're working on some new tools for 2022 that will also help patients find some of those trials, especially if your doctor's not aware or you're just making sure you want to double check. Last thing is for Richie to bring us home with, you know, you've dealt with this from a personal experience, you have the medical background as well. What is sort of the big key takeaway to some people out there that either have a rare kidney cancer type or they're in a population that's not as often studied in kidney cancer or some of those disparate populations, as far as being their own best advocate in moving things forward?
Advocacy is the key to getting anything done. I suggest that if the person is too sick to advocate for themselves, that their loved one be an advocate for them. I know that in my case, being in the medical field, I knew various avenues that I could take. For instance, when my son was denied payment, well, not my son, but the hospital bills were $500,000. And we were told that he couldn't have any care or couldn't be admitted to MD Anderson because of pre-existing conditions. So it's things like this that you have to be an advocate for. And even though his hospital bills weren't getting paid, I had to be an advocate and know the next avenue. So I suggest that you utilize your resources, utilize the community-based organizations that focus on rare cancers or Kidney Cancer Association. And we're so excited to be a part of KCA because I know for a fact that when Chris was diagnosed in 2011, there was not any mention of REMC with any other organization. And I was sent from kidney organization to sickle cell organizations. No one could help me. So it's extremely important that you tap into the resources that are now available to you.
Great. Well, I want to thank this whole panel was wonderful in terms of giving us the different perspectives for some populations that aren't often part of main talks.